Hi, everyone, and welcome back to another episode of Overfilled the podcast. I'm Jamie Kuzner, and I'm joined by my two optometry besties, Brooke Messer and Jason Jedlicka. So we're here to talk to you about the life of being a scleral lens fitter and what overfilled us and different topics in the scleral lens realm. So today we're actually going to have Brooke walk us through a really cool case, looking at how she uses her scleral profilometry to really refine her fits. And I think she has a really interesting case for us. So kind of just not just clicking a button and going from there to design the lens, but how she really dissects all that data that she's getting to refine it. So that will be really fun. If you guys do have a way to watch this via YouTube, that would be great because you can actually see the images that she's going to show. If not, we'll try to talk through the case as well. But before we dive into the case, let's talk about what overfilled us this week. So I'll let you go first, Brooke. What overfilled you?
Yeah, so I just had kind of a routine week of patients, and most of my patients with keratoconus this week had already been cross-linked. And so in a way, like my overfilled for the week is just corneal cross-linking. It's so nice to be able to see, like, one of my younger patients was 19. I had another guy who was like 23, 24, and then even a gentleman who was cross-linked maybe 4 or 5 years ago, and he was like 50. And so just to be able to do, we do the scleral assessment, they come in, we check, see how they're doing, take the lenses off, do the pentacam, and then to be able to see just such consistency numbers year over year, even in our younger patients. To me, that's just, God, like what amazing technology that we finally have after like years and years of, like the CLEC research and the CLEC data on like, hey, this is how we manage progressive KC. Now we actually have the opportunity to stabilize these eyes. And at our clinic, we actually have 2 corneal cross-linking studies coming up, both sponsored by Glaukos. And so to me, that's awesome in that like Glaukos recently just got the epithelium on technique FDA approved, and they're already pushing for better or faster, better patient experience treatments in in corneal cross-linking. And so I'm just overfilled by the stability of my patients with KC.
That is so great too. And I think about that a lot also. And it's like the fact that they can stay in glasses a lot of times, or maybe they only have one eye in a scleral and the other eye in a soft lens. Or they can just choose not to wear their scleral if they don't want the hassle of it and see 20/30 in their bad eye. Like it's so
Yeah.
amazing.
And
And
even
I
having
tell them all the time, they're so
oh,
lucky. They're so lucky. I'm like, you're so lucky. I'm like, you know how many of my patients wish that they could see as good as you do? It's
yes.
awesome.
And sorry, I was just like, again, continuing to be overfilled. Even just having like the 10-year data, last year, the year before, whatever, on like 10 years of cross-linking stability on the epithelium off technique. And so just to be able to tell patients that like, yeah, we have 10 years of stable data on patients who've had epithelium off corneal cross-linking. So I can really recommend it with confidence. So anyway, that's just where I was at. It was so nice not to have to counsel anybody about, hey, you're getting worse, because we don't do that here. We just
Right.
You're just the best clinic. So I'll go next. My overfilled, I've had a lot of really good ones lately. I don't know. I had this woman, 72-year-old that came in and she was referred in because she has graft versus host disease after she had cancer treatments, unfortunately, and has never worn a contact lens in her life. Her eyes so dry. So even looking at her picture on her driver's license, when you look at her chart, like her eyes are barely open. And just looking at her now, like walking around the office with her lenses in and having her eyes fully open is amazing. And she came in 3 different times to learn how to use these lenses just because her aperture was so small. She had never worn a contact before. She ended up using a stand, lens base. Shout out to lens base. I love it. That was the golden ticket that worked for her. And she was so happy that I was going over a recap of solutions and taking care of everything and our follow-up appointment coming up in a week or 2. And she just randomly hugged me in the middle of me talking. And she was just like, thank you so much. I'm so grateful for you. And it was great, and so my team loves seeing her too and encouraging her. So it's just one of those overfilled things.
Those
Makes
are
you happy.
the best. How about you, Jason?
Well, I thought maybe I would have news of a grandchild to talk about today as an overfilled moment, but I don't yet. He's still not here. So I did have a patient this week, though, who was new to us, referred in. and keratoconic. Has not had cross-linking, can't afford it. So something we're working on in that regard. But wearing glasses 20/40, 2200, never worn contacts, never had the means, or the care to try them. Nobody ever recommended, nobody ever told him that he could do, has no financial means at all. But we did see him because we got approval through a grant to help him, and did our usual, took our scans. We'll talk through in a minute how we did that, put lenses on him in the office. And he's young enough that even though his lenses were kind of over minusing him by a diopter or two, he was like 20/20 in each eye. And he was just one of those where my student came out and told me that what they got. And she said, yeah, he was 20/20, and he started crying. And so it's just one of those moments that we all live for. But he's a guy who walks around wearing a patch over one eye half the time because his left eye is so blurry, gets so much glare from it. It's just better to close it off than even to use it. So really excited to get him into lenses. And like I said, now we just need to worry about getting him cross-linked because he obviously has good visual potential in these two eyes. Yeah.
Awesome.
Yeah.
So great.
Yeah. All right, let's talk about topography.
Scleral profilometry. And can you load up our slides, Jason? And I'll. So this is, he's about, I would say he's young 30s and has, pretty good keratoconus in both eyes. This is his left eye, and it's definitely the worst eye. And he came in for a scleral fitting and have had like a little bit of bumps as the fitting has been going on. And so I thought, well, I'm going to pick your guys' brains on looking at this to make sure that I started on the right track. And so I thought we could kind of look at the quality of the scan first, and then on the next slide are the numbers enlarged. We have it both at what I would call the chamber diameter, which is where the chamber of the lens, that limbal clearance curve first hits the ocular surface. So I call that the chamber diameter, or we do. And then I also have the total lens diameter and talking about the edge of the lens and how that looks. And so as we have this conversation here and you guys provide some insight into what you see on these images, I'll kind of comment on, hey, this is what's been happening in the fit, and maybe we can solve some of my problems today. So Jason, will you just kind of take us through when you look at a CSP for the first time? This is a CSP, scleral profilometry. What do you look at first?
Well, the first thing that I would notice is that this is two scans stitched together, as evidenced by the coverage map, which is partially yellow and a little bit of blue. So yellow is scan 1, blue is scan 2 added to it, stitched together. The gray at the bottom is not measured data. So we have to keep in mind that that part of our scan on our picture on the right is extrapolated. So it's not real measured data. Where it's gray, it didn't measure anything. So when the map has something that shows up where it was gray on your scan, it's just making that information up.
And that's the dots in the purple region at the bottom on the, on the data.
So that's, and for whatever it's worth, again, if you were going to use this map to make a totally software-based design database lens, that might be a little bit of an issue. You might expect it to be a little suboptimal. But in terms of if we're using this for a diagnostic fitting, it's really not that critical. Again, we can see what the basics of this map are. So I will say, again, I don't know, Brooke, do you guys, when you do your CSPs, do you anesthetize your patients?
I think they do.
Yeah, we always do. And since we've anesthetized patients in the last year or two routinely, we're able to get single scans on most every patient. We don't have to stitch. And I do think that stitching does have an impact on your data to an extent. So if you can ever get a non-stitched scan, I think you're going to get a little better outcomes when possible. Again, this is
when the brow is really prominent and it's like all you have to do is push that lid back. You can't really like get it off the globe. What do you do? Yeah.
I mean, you can't. Obviously, we have the head spacers, right? And so sometimes, for example, if you start off doing a CSP and you don't have a head spacer on, and you've got you get the whole lower part and you're missing the top 2 or 3 millimeters superiorly, you can obviously add another scan, right? So put in a spacer and repeat it. Now, sometimes what happens is your second scan with the spacer, you'll get a lot more superiorly and you'll still get everything inferiorly. And then of course you just trash your first one and don't bother stitching them and just keep the second one only. Anytime you do a repeat scan that's better than the one you already have, you should always discard the inferior prior ones. Otherwise, the instrument will always use that as the basis and just add the new data to your old one. So you always want to pick, if you do a second or third scan and like say your third scan is better than your first two, you need to trash the first two, keep the third one, and then add a fourth if you want to, or a second one to that third scan. So you always want to keep your best scan as your number one scan, and then just add more scans to it if you need to fill in. So that's just looking at the overview. That's the first thing I think of is again, that this is 2 scans that I'm missing a little bit of inferior data. But for general purposes of fitting, this is a fine scan. And the other thing too, again, if you look at the scan on the right, it doesn't look like it's loaded with artifact like you sometimes get when you stitch scans. Like sometimes you get an abrupt line drawn through your scan, or you're like, okay, well, that's not real because I can tell it had trouble stitching this together. This does not look like there's any difficulty stitching it.
And that's what I thought too. I was like, wow, this is a pretty clean scan. And it's mostly regular, you know, the superior axis and the inferior axis, you know, they're slightly skewed, but overall it looks pretty with the rule. So when I saw this picture, I was like, oh, slam dunk. We're going to have bielevation. We're going to have some haptic toricity, and this is going to be just super easy. We're going to lock it in place, throw on an HOA, and this guy's going to be super happy.
Yeah. The other thing that I think sometimes we skip right to the sclera when we look at these, but looking at the corneal part, this is a pretty bad cone. I mean, it doesn't look impressive on a CFP, but when you see that yellowish, orangish spot almost with the deep blue above it on the superior cornea up there on 11, that's a pretty bad cone. It just doesn't look that bad because in the context of everything else about this eye, the corneal shaped stuff gets washed out. But if you did a regular topography of just the cornea, that would be a pretty pronounced cone, I would imagine.
Yeah, he definitely is a more severe cone. And you can even see there that we'll move into in a second, but the recommended scleral lens sagittal depth is around 5,300. So that for a Zen lens, that's
for a 16 too. That's a pretty
16. Yeah.
Okay. So do you want to walk through this part?
So these are, we just on the previous slide, we were just looking at those color maps, and then now we're looking at the data associated with those previous color maps. And so, you know, at top we have the ring diameter, and we set that based on the corneal diameter. So I'm following Zen lens rules here, and this is certainly applicable to whatever scleral lens you use. I'm sure that those, you know, lenses also have rules on corneal size and lens diameter and all that. So I'm using Zen lens rules here, and the horizontal white to white was 11.8, and the Zen lens rule is, you know, 11.8 and larger we go 17, and then smaller we go 16. On this, in my experience, like my Pentacam, I tend to fudge toward the 16 with the 11.8, which is why I did this with this particular scan. 11.9 is when I definitely do a 17, but for whatever reason, just like my measurements, I tend to find that if I have an 11.8 cornea, 17 lens with that chamber size is a little too big. And so I went 16 on this guy just based on experience. However, because I've been having a little bit of trouble, maybe I should try on a 17. So I'll make note of that. Anyway, ring diameter at the very top right, that's our selected lens diameter. So I chose a 16 here. And then we have the sagittal heights in the flat and steep meridians, and then the difference. And again, this is at the total, at the 16 millimeter cord. We have that difference, which is a lot, 660 microns of toricity at 16 millimeters, which is a lot.
That's a lot.
And then we have our central clearance, just moving down those numbers there. Central clearance prediction set at 300. And so that calculates, hey, if you're going to grab a Zen lens or a lens out of your kit, we want something around, this one says 5288 microns, and so 5,300. So I was looking for about that amount. Excuse me. And so Jason, why don't you take it from here?
Well, The other thing I think we should go back to too is, again, this is a cone patient, so we're going to do a prolate design as
Mhm.
as opposed to an oblate. So for me, what I would do is I grab my fitting set and I'd pull out a 16 millimeter prolate design lens that has toricity in it. Now, in this case, this is a lot of toricity, and even my
Mhm.
general toric diagnostic lens is going to fall way, 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 way short. So, what we would look at then is, as you were alluding to, is that internal chamber diameter, which in this case is we're going to use 13. So 12.8 to 13, somewhere in there is about the beginning of the haptic or the end of the vaulting chamber. And in this case, the critical thing to look at is that sag height astigmatism number there where it says 219. So that's telling us how much toricity is going inside the chamber, the vaulting part of the lens, and then subtracting that from the total astigmatism, which was 659. That gives us whatever that 440 roughly
Mhm.
that we need to put in the haptic. So again, what we always want to do with a scleral is we want to put the toricity in the part of the lens that corresponds to the part of the eye where the toricity is found. Okay, so if we had an eye with 659 of toricity and we put all 659 in the haptic, then at the internal part of our haptic, we are badly misaligned.
Mhm.
The
It'd be
limbo
rough,
So,
hard.
yeah. So in this case, at 659, and even though there's only 200 and something internally, I still would probably reach for a bielevation diagnostic lens if I had one,
Yep.
because the bielevation is going to have a lot more toricity built into the lens. But
I have
let's
a question for you then, if I can
say you
interject
don't.
you.
Yeah, go ahead. Yeah.
What if, because sometimes we have a bioelevation kit, what if you had to pick between a bioelevation, but it was overvolted by like 500 microns more than you want, or just a standard toric diagnostic with a appropriate volt, what would you pick if you had to assess it?
I would do the bielevation.
Okay.
So, it depends.
I know, because sometimes I fall into this too, where it's like I want to do the bioelevation diagnostic, but I
Yeah.
don't want to overvolt it like crazy and everything kind of
Yeah.
goes sideways.
So again, the reality is, in this case, let's pick, for example, in this case, and let's say I had a lens that had a spherical chamber and 180 microns of toricity in the haptic. My other option is a lens with 350 microns of toricity in the chamber and 0 in the haptic. Now, I'm not saying that that's what we all have. I'm just saying if those were my options. Okay.
Mhm.
If those were my options, I would rather go with just the toric haptic, because if my lens has 350 of bielevation and my eye only has 219, then I'm really only transmitting 219 microns of that toricity through the entire lens anyway. I'm losing the other part in the other meridians over vaulting. So it's not like you're actually putting on a lens with 350 microns of toricity and looking at the edges. Because you land in the other meridian and overvault in your shallow, you don't actually transmit the whole 350 through to the edge of the lens.
Mhm.
Okay, so it can sometimes throw you off. Now, personally, if this eye had 319 instead of 219, I would absolutely pick the bielevation. I just think that right at 219, it's far enough away from my 350 lens that I would probably just pick the toric haptic. Now, that said, if my lens had 350 of bielevation and a toric haptic, another 180 in the haptic, I would definitely use the bielevation. It just depends on what your bielevation lens has in it. Because I know some people's, they've made some bielevation lenses have chamber toricity, and those lenses then have no toricity at all in the haptic, and others have a toric haptic and a toric chamber, both. I think in this case, because there's a lot more toricity in the edge or in the sclera than there is in the chamber, I'd probably lean towards not a bielevation. If there was more toricity in the chamber and less in the edge, or if the chamber toricity was closer to the 350, I would go to the bioelevation. So it's one of those where you go with your gut, and it's, I think, as you pick one way to work, like Brooke, you said, I'd probably do the bioelevation, probably because you pull bioelevation trials a lot. So you're really comfortable working with looking at those fits. I'm not. And so I only pull them when I've got closer to the same amount that's in my lens.
Yeah,
So
I should add that as soon as I feel like I'm missing something in my diagnostic set, I order it. And so I have like, I have like Z10 with 250 microns of bioelevation in the toricity, and I have some oblates with or oblate lenses with bioelevation. And so if you're specifically talking Zen lens, I have more bioelevation lenses than just the right wing of the fitting set that comes with the whatever 300 and 450.
Yeah.
Again, like mine is, I have like my fitting set's pretty messy. I got lots of random vials in there and stuff. And so I do have smaller amounts. I have some 150 micron bioelevation lenses. And so I try and get that on just because I think like centering around the limbus and getting that like nice, even tear film chamber in the beginning helps me a lot. And in this particular one, I might have had a 250 bioelevation lens. And so that's probably what I put on in that depth. I can't quite remember, but and the other thing that I think is, at least in my technique, is thankfully I have time with my patients. I can, put more than one diagnostic lens on, or more than two, even if I want. And, I think some docs kind of tout the fact that it's like, oh, I only need one lens. I only need one diagnostic lens to put on the eye, and then I can order it from there because I'm really good. I'm not. So I like to put on, like, sometimes I'll put on a 14.8 and a 16.0 if I have a small cornea, or if I have a 17, I'll put on a 15.4 as well. And I'll try haptic toricity versus chamber toricity. Because to me, I just like to have all that information, because each lens gives you something a little bit different. And then I kind of piece together based on that entire fitting. And so if I put on 3 lenses, or 4 sometimes, I maybe don't go 4 that often, but I would say I often put on 3 lenses because I just like to see what it shows. I think it's valuable for the resident to see the think process on, like, hey, if I see this, try this, or, gather something totally different from a different diameter.
Well, I think
there's no golden first trial, in a case like this.
Well, but I think in your case, the point there is that you have you've got a lot of old lenses that you've organized in a way where that you can use them again in future fittings.
Yes.
To the person who's just got a fitting set, putting on 3 different lenses is probably purposeless, because nothing else in that set's going to work better than the good one. But to your point is, if you've accumulated a variety, so if you fit a good number of lenses, at some point you ought to start looking in, because you just totally inspired me as we're doing this call, that I'm going to make up a new set of bioelevation lenses exactly the way I want them, with the exact amounts I want, just like you got. And so if you've got more lenses with more options and parameters like that, then it does actually work to put on more lenses, because you process where you'd have to have them come back and put on a spherical chamber toric haptic lens, and then I could put on a toric chamber spherical haptic lens and see the difference. I've just maybe saved myself a bad order and an extra appointment to fix that. But you've got to have a variety of lenses of different parameters to do that with, that each have their own merits. You don't just want to work your way through your set trying on everything in your basic set.
And if you guys are wondering how you get these extra lenses, it's not just a Jamie, Brooke, Jason thing. You can always order whatever diagnostic you want. I think it's like 20 or 25 bucks.
Yep.
Like you can ask, like, I mean, I can't speak for all labs, but at least with ZenLens, you can order a diagnostic of whatever parameters you want, and they'll send it to you for whatever the cost is to make a diagnostic lens. So don't think this is just special treatment that Brooke has a mega 150 lens set. So
I just do ask,
keep that in your mind too.
Time is money as well. And, every time you ship a lens, there's shipping costs. And so if I use those more customized diagnostic lenses more than once, I'm covering that extra fit shipping. And So to me, it's worth it. And I just really like being able to take a lot of images and, take my time to really try and dive in and see how close I can get with that first lens. In this case, again, if I would have been working with like my 300 micron bielevation or my toric haptics, to be honest, I probably tried both just to try and see which one gives me better centering and how I like the edges and see, see where it looks. I would agree with you, Jason, that there's some value in having like a bielevation lens and then continued steepening through the haptic in that same meridian. So maybe that's my next $25 diagnostic lens is just like super steep haptic alongside moderate amount of bielevation.
Yeah.
What do you got next?
The other thing I was going to say with this is that you can tell too, and this is really helpful, again, I think in prepping your patient, because we talk so much about patients and how they interpret and how, the confidence they have in you and their impression of you as a practitioner is if you've got a lens that is undercorrecting their toricity by 300 microns, it's going to be loose. And that. So tell the patient that before you put it on. I'm going to put this lens on. It's the closest one I've got, but it undercorrects the shape of your eye. And so when you blink, you're going to feel it rub your lid right up in this area, because then instead of you looking like you don't know what you're doing when they first put it on and it bothers them, you look brilliant because you could predict what they were going to feel before they ever put the lens on. It's just taking that moment and turning it from a potential for the patient to question you as an expert and thinking you are an expert with the exact same lens and the same outcome.
I often talk about fogging like that too. If I know I got my first lens and it was moving, like, oh, this lens might fog. So just, wear it until you need to take it off. You can put it back in if you want. You don't have to, just know that that's what we're working toward and that, I'm expecting you to have some fogging. Yep. Something else that I want to add on how I use these numbers and these scans is predicted rotation. So when I'm looking at these images right here, it says the steep slope or the steep meridian is at 107 degrees. And so that's going to be, 17 to the right. So it tells you like where the top portion is, and it's 107 degrees if you were looking at a phoropter dial. And so if you draw that all the way down to the inferior portion, that's going to be 17 to the right. So if I did have a patient that I knew would need their astigmatism correction in the first lens to see well, then I would incorporate the astigmatism into the first lens that's ordered. Smaller amounts, a diopter or less, I don't always add in astigmatism correction right away, but if I knew they needed it, I would predict this to roughly land at 17 degrees to the right. If you go back to the 16 millimeter, this one here says 14 to the right. And so I know that my sclera and my chamber are pretty well lined up. So, if you could put it at like 15 to the right and be pretty darn close with that first lens that comes in. And that's also valuable. So that, again, you can just hone in on that vision correction even faster if you know that they're going to need that astigmatism correction.
Yeah. And the other thing too, of course, is in this case where if your diagnostic lens, let's say, only has 180 and your eye has 650, you would expect some flexure of the lens. And so where's that flexure going to show up? Your overfraction have an axis around 15. So if you overfract and you get like +1 - 175 axis 15, you are not putting that cylinder in the lens because once you fix the fit, it will go away.
Yep. And if it's on that meridian, yeah.
But if the patient has an overfraction where their cylinder is axis 75, has nothing to do with flexure at all. That is residual. And you might consider putting some in, maybe not, I don't know, but I would be far more likely to put cylinder in that did not match the shape of the eye, knowing it's not flexure related, than if your overfraction matches exactly where your flat meridian or marks are, you better know that that's flexure. And to not put that in, you better fix the fit, right?
And sometimes I'll undershoot the astigmatism too, like anticipating some improvement there. And then it just gives you a little room on rotation too. So rather than going for, $1.75, maybe I'd add in a 1, knowing that it's going to help and that I still have some wiggle room on rotation without messing up their vision.
So you fitted this patient in lenses.
Yeah.
Did you say you had some issues or
Yeah, I am going to go back and look at how much bielevation I have in there compared to the toricity, because maybe I'm undershooting the haptic and just, need to get back to the basics on these. Because he still has quite a bit of lens movement, and he has, his lens is pumping in debris at like 1 o'clock and 7 o'clock. So his major meridians are here, but he's pumping in just off axis. And so he was another one that I was thinking, well, maybe I'll have him look. He doesn't look like he should need a quadrant specific chamber or, that kind of thing. And even at the top, those numbers are not all that different, nasal temporal and superior inferior to where I would need quad sags. I didn't think so. So my first troubleshooting will be to make sure that my chamber isn't over vaulted or too much bielevation, and then make sure I get enough of that in the haptic. This guy's been pretty particular about his vision, and he really needs the HOAs to see well, as you would imagine with this kind of cone. And so I took a chance and I asked for a little more haptic toricity on the last one, and I threw the HOA correction in there. So we'll see what happens.
I have a
like ready to, he complains about doubling and like struggles with his vision quality. And so I'm like, this is enough, like messing with the fit. Even though we're still pumping in a little debris, I'm just going to throw the optics on there, and hopefully I did enough.
I have a question for you. Do you know what base curve he's in?
I don't offhand, and I apologize.
Because I'm just wondering, I don't know if maybe he needs a steeper base curve just because of how his cone is and how drastically it, because I know we're looking at, bielevation like chamber, but also like more internal. I wonder if it's just that, if we can steeping the base curve might help a little bit too, to give a little bit better alignment. Like you don't want to go crazy. Like it looks like its best fit sphere is like 5.6. I mean, I wouldn't do a 5.6, but maybe that might help. I found that has helped a little bit with that mid peripheral clearance. So I
love using best fit sphere.
Yeah, me too.
Match up that chamber. It makes such a difference.
I think
so I don't know.
What you're saying is really valid in that when you steepen up the base curve, but you don't change the total sag, what you're really doing is you're pulling down the mid periphery. Which is then bringing your limbal clearance zone in over the limbus at a lower profile.
May snug up some fogging.
Which will snug up because it may draw the limbus up a little bit into the back of the lens and lock that off. So again, to recap, when you steepen the base curve but keep the sag the same, you're going to pull the mid peripheral part of the lens down, and then you're as you go across the limbus, you're going to have a lower profile across the limbus into your landing point.
Yeah.
That might be it, to be honest.
That was one of the changes I did make on this one, the last order. I did decrease his limbal clearance in the vertical area too. But I'm going to go back and look at the base curve for sure. And my comparison on the haptic versus chamber toricity and see where I'm at.
One thing that you mentioned too, I think is interesting in this case is a lot of times, like you would look at this map and you might think I'm going to get debris coming in at like 11 and 6-ish because that's where it's deepest. But often what happens, it's not there. It's more at the transition between the steep and flat zone, which in this case is at 1 and 7.
Yep. And that's exactly where
you abruptly change from elevated to very deep. There's a very sharp transition right at axis 75 and again down at axis
240.
Whatever, at 240-ish. And what may happen again is we don't know how these lenses are exactly made. The transition from the low point, the deep point at 11 o'clock to the high point at 2 o'clock may be very gradual, where our eye is more abrupt. And so we don't, even though we're aligning at points A, B, C, and D, even though we're aligning at 11, 2, 5, and 8 or whatever, in between those points, we're not necessarily following the same contour that the eye is following. And it's near impossible to in a lot of times. So we just have to remind our patients that, hey, this is a messed up eye in terms of the amount of toricity. If you think back, like we talked about last episode, I had a guy who we were refitting because he tried sclerals 10 years ago and hated them because he's got 500 microns of toricity. And I'm sure 10 years ago, whoever fitted him in a sphere. It's like, okay, look how much better we can do now, to the point where we can even consider having a patient like this not have any fogging, or it's minimal. 15 years ago, we would have said, take your lens out every 2 hours and reapply it to get rid of the fogging. And that's the best you can ask for. So sometimes it's a matter of saying, hey, it's just your eye is just a little bit crazy and we just can't quite make a lens that's as good. Or I can, but you're going to have to plunk down, $4,000 a lens to get that kind of fits.
Yeah.
Yeah.
I was going to say, if you did like a molded lens, they could actually just make it, contour exactly at that point in time when you do the mold, or a freeform, I guess. I know that would be tricky with a freeform though, because of how the map is with him too. So that would be tricky trying to do a freeform when you don't have 100% map data.
Yeah. But you got to remember too, and we've talked about this before, the eye is not the same 2 days in a row. And so you could look at that
I know.
and say, oh, I'm just gonna mold that thing and it'll be perfect.
Yeah.
And you mold it and it's not perfect. You go, wait, I thought this was gonna be perfect. It's like, no, because the eye is different. The eye is different tomorrow.
Yep. The con is a living, breathing beast.
Yep.
That's why I said asterisk at the time of the mold. On that one day, that lens would have been perfect.
We did a little pilot a few years ago, and I should share this on some episode, where I had somebody map my eye like 5 times consecutively for 3 days consecutively. And what was really cool is within the day, 5 consecutive scans, everything was within about 40 to 50 microns each day. And between day 1 and day 2, the average of day 1 and the average of day 2 was literally like 1 micron difference. You're like, holy cow. On day 3, the average of the 5 was like 75 microns different. So something happened between day 2 and day 3 that changed the shape of my eye pretty noticeably. So there is intertest variability, obviously, but there's also interday variability. And sometimes that interday variability can be 100 microns. And so sometimes we just have to tell our patients, be happy for what you have.
It's tough. It's hard. Again, maybe with this patient, maybe the HOAs are more important than the fogging, and that getting the HOAs corrected is maybe the ticket here. Because of course, I've been holding, and he continues to struggle with his vision because he's like 20, 30 plus, but exceptionally doubled. He's like a 1.5. So he's like, his aberrations are super high. And, so he's just like waiting. And again, like maybe if the doubling was gone, the fogging would be like this big of an issue. But now it's like doubled and fogging. So we have lots of stuff to navigate for him. So that's why I was just like, okay, fine. I'm just going to do the HOAs and I'll see what they'll let me do. I use the OVITs to measure my HOAs, and, they would like everything to be finalized, but I'm going to try and push my limits on this one.
I've honestly, I know I've changed my haptic by a little tiny bit, and it has not affected anything. I think the main thing is that they don't want it to rotate.
Yeah. And I'm not,
you know what I mean? Or flexing, or if it was like flexing and then not flexing, I think I don't know. Yeah. I can't speak for them. They're going to be like, Jamie, don't say that on me. But I've done it too.
On an eye like this with that much toricity, if you change the haptic by 30 or 60 microns, it's not going to change the rotation.
He's got so much toricity. He's locked.
It's locked in.
Yeah.
So,
it's like 17 to the right. Again, and that's what I told him. Like, I need to get this fit going, and like he's not rotating. I'm not concerned. And of course, on the Zen lens side, they're like, yeah, whatever. Like, we'll do whatever you tell us. But so again, like my paragraph, whatever. Is like, and then at the bottom I wrote like, these are all small changes, but which they're really not, but we'll see what happens. Right. So I'll try and bring an update next time, and see if my, my rebellious order made a difference.
Sounds good.
Yeah.
That was so good, and I feel like I always learn so much, even just talking to you guys about how to dissect things, because I don't have CSP, yet, hopefully at some point. I have an eaglet, so it's interesting to look at how other profilometers and how you guys dissect the data on it, so all good points. I love
And I
it.
still think there's value in just understanding chords, what the numbers tell us, and you can use that across any platform. So hopefully, hopefully everyone can take a little bit from this.
There you go.
Yeah. Jason, we hope that everything goes great this week for your family.
Yeah,
and,
thank you.
that you have a really special Overfilled next week.
I'm sure we will, God willing.
Yep. Yeah. So
if you want to get a hold of us, you know where to find us. Social media, around Facebook, Insta, we're on Spotify, YouTube, especially if you want to see all these really great images and kind of dissect them with us as we're talking through them. YouTube is the best way. Obviously, Spotify, great for, car rides and things like that. But if you want to see our lovely faces and look at the images, YouTube is there for you. And then, of course, send us your cases. If you have something interesting like this too, you can send it to us and we'll kind of dissect it and think, this is how we would have started it, what we would have done. And maybe there's a little thing that you've, overlooked, like, oh, shoot, maybe I should try a different diameter. Or maybe I had, I need more bioelevation or toricity. So send us your cases, even if it's just a scan. We can kind of talk through our fit process and have some fun with it and discuss with all of you guys. But thanks again for joining us for another episode. We'll see you next week.
Have a great week.